Guys, a talk on kidney transplant immunobiology. So the main thrust of this is that the ASN wants you to know the underpinnings of why and how the immune system works and why we what we use to immunosuppress during kidney transplants. So this is pretty much um, directed towards things that show up on your board exam. So it's going to be a review of immunology and then kidney immunology and kidney transplants in particular. So it's not very technical. And then if somebody has questions, just ask me right in the middle of the presentation. It's usually easier than having to go back to slides. Um, there's sort of two types of immunity. I'm sure you guys know. One is what's called innate immunity. So that recognizes um, molecular patterns on cell surfaces that are well preserved, like bacteria. Um, and that is something that is pretty much universal to any multicellular organism. Um, and that includes things like neutrophils, monocytes, and macrophages and natural killer cells, and proteins like complement, um, and certain types of opsonization proteins, I should say. So proteins that help your immune system recognize non-cell bacteria. And then the big one that we look at is adaptive immunity. So that's predominantly found in vertebrates. And it's pretty well preserved. So all vertebrates share adaptive immunity evolutionarily, meaning you can find similar cells in like a hagfish, like fish without jaws, which are like the most basic sort of vertebrates. Um, and this is something that is sort of continuously a learned response to different types of antigens or epitopes. And then before I go on, an antibody binds an antigen, it recognizes an epitope. An epitope is a sequence of amino acids that are in a certain shape that a protein is folded into that is recognized by an antibody. So those are sort of those terms, and stop me if it gets confusing. The MHC stands for Major Histocompatibility Complex. The name suggests we found out what it was based on us trying to do transplants, usually xenotransplants, and recognizing that it went catastrophically wrong, and it was because you recognize non-self so aggressively. So major histocompatibility complex is the term, and it's made of these proteins that present antigens to predominantly T cells. And it's termed HLA in humans or human leukocyte antigen because it's found on multiple immune cells. Um, so the point of this is that T cells, you don't want your T cells, which are your predominant your net predominant cytotoxic cells or cells that kill things, to recognize just stuff floating around in you, because it can be quite catastrophic. You want it to recognize something when it's presented in a controlled fashion by a cell, and then has a second signal saying, "Hey, now I want you to proliferate and kill this thing, recognize and kill this thing." And then as that happens, they also express a separate signal that says, once you are done, I want you to essentially commit, uh, basically destroy yourself. So there's a process that cells can undergo of controlled self-destruction. There's a sort of a long name for it called phagocytosis. Um, and it's pretty uncommon for other cells to do that. So there's two critical properties of HLA antigens, and number one is that they're variable and that they can recognize self and non-self. And then you get one set from each parent. Um, and so that doesn't mean that just one is expressed from mom only or one is expressed from dad. They're both expressed. And so it's called codominant expression. Um, this is, I think, kind of underappreciated, but if you look at this, the one on the left is a little bit confusing for you guys, but look at the one on the right. This just looks at the frequency of HLA molecules. So this is unusual for a country to have this degree of heterogeneity in the expression of these molecules. You can sort of think of why this is so common in the US. um, because it's a very diverse population. And So, it's the adaptive advantage of these MHC molecules and the variability is that it allows you to distinguish self from non-self and kill predominantly infectious organisms. There is a pretty big role also for clearing cellular debris and for protection against cancers. Um, and unfortunately, this means it's hard to transplant people because we have different MHC molecules. And so unless you're identical, you will have a response to a transplant from someone else to their MHC molecules, which are different than yours. And that's essentially rejection. So these are the sort of molecular structures. You don't really have to know them. Just know that there's two classes, one and two. Um, and the class one is found on all nucleated cells. So there's cells that don't express it. So there's some nucleated cells in the eye. Obviously, mature red blood cells, erythrocytes don't express it. Um, and these are particularly important for presenting intracellular antigens to T cells. So obviously, viruses are big. And then this is the class two. And these are found on what are called antigen presenting cells. So these are cells that specialize in presenting foreign antigens via the MHC to T cells, and they present them to CD4 T cells or helper T cells, which don't directly kill the cell. Um, I'll explain what they do later on. And so I just want you to keep in mind, like two is antigen presenting cells, and you think, well, we see this in kidney transplant. Why does this happen in kidney transplant? It's because you have they're expressed in endothelial cells. So that's kind of the most common reason. So there's sort of two big ways that you can activate T cells. One is that your the the indirect activation, that bottom part, is the one that will be most common. So that is where your T cells recognize antigens from your own antigen presenting cells, and you activate the CD4 pathway. And so that's exactly how it occurs in nature, right? You express something foreign, it's presented to a T cell, the T cell goes down the pathway of activating your immune system. The direct activation pathway is what's sort of unique to kidney transplant. And that is where the donor antigen presenting cells, meaning the antigen presenting cells that are in the transplanted kidney that came from that donor, are expressing HLA antigens, and your T cells are recognizing and attacking the donor, the kidney. And that is early rejection or early antibody-mediated rejection. And that really only can happen in the setting of transplant. There's not really very many other ways that you can have a a cell that isn't your own presenting antigen to your own cells. And so when you see somebody, and these donor antigen presenting cells, they go away in about 6 weeks. So we see a lot of early rejection within that first 6 weeks. That's why we call it early rejection, early T cell rejection. And so the other part I mentioned, so you have the MHC, it's presenting an antigen to a T cell receptor, and that's activating the T cell. But you need a second co-stimulation. And that's important because that's one of the therapeutic targets we use in transplantation. Without this signal, T cells will undergo apoptosis. And that is specifically because this similar event happens in the thymus when you are teaching your T cells how to recognize self and non-self. So if it doesn't recognize something that it should, then it is put down the apoptosis pathway. And then if it recognizes something that is yourself, it's also put down the apoptosis pathway. And so that's the second signal, and that's another therapeutic area. You don't really have to know all these. The important thing is that the way your T cells proliferate is through cytokines. And that's going to be a very big term because that's what is the Th1 pathways is very big in cytokines, and many of these are now therapeutic targets, both in and out of transplant. Probably the one that, if you guys know for your boards, probably the one you should know most is what are called mTOR inhibitors, because we do take care of patients with hamartomatous syndromes like tuberous sclerosis. And so that's probably the big one that'll be on your boards. But just know that this is the third step in after co-stimulation is you get like proliferation because of cytokine release. So this is specialization of T cells. So you have your CD8 or T cell that's now binding and co-stimulated, and then it makes cytotoxic T cells, and these are cells that directly kill the cell. And then you have the MHC2 that binds CD4 T cells, and these are multiple different types that subspecialize. But the important thing is that these help cytotoxic T cells, they help B cells make antibodies, and they're important for macrophage recruitment. Um, and so here we go. Yes. So these are the two big pathways. So for T cell mediated rejection, you have a CD8 cytotoxic T cell that directly kills the cell. That's it. It's very straightforward. For B cell mediated rejection, it's more complicated. So you have a MHC class 2 that is activates CD4 cells, and that releases proliferative signals that activate CD8 T cells, B cells, and macrophages. And that has a variety of effects that are related to complement. So that's B cell or antibody mediated rejection. And so in your head for the boards, just remember MHC1, HLA1, T cell, MHC2, HLA2, B cell. And that's the easiest way to think about it for that. They call this a delayed type hypersensitivity reaction. That's sort of a how allergy and immunology refers to these, but it's essentially saying that you are generating this like large reaction to make antibodies, and I'll kind of go over why that's important for long term as well. Um, and so the predominant immune response in rejection is Th1, which is a CD4 type reaction. And that I think is another thing they wanted you to know for your board. So I'm sure you guys remember about why people get sensitized. So the three big things are you get transfusion. So this is not just blood, but any sort of product. This is becoming less and less common now that we have great ways to essentially make sure the blood is leukoreduced. But it used to be more common. A very sensitizing event is pregnancy. So you can imagine pregnancy is a pretty complicated event. Your body has to dampen the immune response because at least half of the antigens that are expressed on the fetus are not the mother's own antigens. And then obviously a prior transplant does increase the degree of sensitization. There are people who don't have any of this who still have um, um, HLA antibodies in their blood. And I think that has often been explained by the fact that you have this sensitization from your diet. Like gut bacteria can cause you to develop these HLA antibodies as well. So these are sort of discussing about B cells. So remember, B cells are antigen presenting cells. They display an antigen on MHC2. It's recognized by CD4 T cells. And then you get the cytokines and co-stimulatory cells that cause the B cell to mature and proliferate. So this is almost like a circular handshake. And B cells, when they mature and proliferate, become plasma cells and memory cells. And plasma cells, you remember from college, they're basically um, um, the factory of the cell, right? They just produce high affinity immunoglobulins. Um, and the Memory cells are cells that oftentimes reside in your bone marrow and are there to remake antigens, remake immunoglobulins if expressed. If you want a parallel, memory plasma cells are the cells that myeloma are derived from. And so you'll notice that we don't use rituximab in myeloma. multiple myeloma, and that is because these cells do not express CD20, like we're so used to treating whatever FSGS or ANCAs with that kind of treatment. These cells express something called CD38. Things that's why sometimes you hear us talk about using daratumumab as a plasma cell depleting therapy. Um, And then I'm not going to go over the whole complement cascade. It's long and complicated, but for your boards, when on biopsies we stain for C4D, on regular kidney biopsies we stain for C3b. Both are complement fragments. Both are fragments that are involved in activation of what's called the classical complement pathway. And so that is how antibodies destroy cells. So that is complement dependent cell destruction. And the only thing you have to know is that, this is why we check complement levels if we're concerned about somebody having an immune complex disease like whatever, lupus or infection related GNs, or IC-MPGN, like those kind of diseases. And that is through the classical pathway. So antibodies kill things through the classical pathway. When you see complement deposition in IgA, IgA doesn't work in the classical pathway. That complement deposition is for different reasons, maybe the alternative pathway, but that's just the important thing to remember is that antibodies, um, especially IgG1 through 3, those antibodies kill things through the classical pathway. Um, and so this is just going over the two ways that we evaluate for transplant sensitivity in a recipient. So, number one, I'm sure you know the uh, cross match. So, that is where you take donor T and B cells, and these cells are derived from when you procure the organ, you take some lymphoid tissue with you for the procurement, and you do flow cytometry with serum from the recipient, meaning the person who's getting the transplant. And if that is positive, then they have antibodies to the donor T or B cells, and that is usually a no-go. There's very few cases where we would transplant somebody that had a positive cross match. And that is because that's a high risk of hyperacute rejection. They have preformed antibodies to the transplant. There's a concern they would immediately reject in the OR and the organ would be destroyed. And that rejection is entirely mediated by you put the organ in, you have these preformed antibodies from the recipient, they recognize the organ, they deposit antibodies, and they immediately start fixing complement and making holes in the cell and destroying it. And that's the mechanism behind that. Um, and so these are just saying that you can tell if it's against T cells, it's MHC class 1. If it's against B cells, it's MHC class 2 because B cells are antigen presenting cells. Um, This is the report. So most labs that do this show this kind of report. And so this is just showing that you see T cell and B cell flow and the result. The MFI is back to here. There's a fluorescent antibody to detect how strong it is, and that's just the MFI stands for mean fluorescence intensity. So the other part of this is like you'll sometimes see us talk about DSA or MFIs for certain DSAs in particular, like A, B, or DR. And so this is how we identify those. You don't have to know how this is exactly done, but this is single bead antigen detection. And so this is how we tell that what particular antibody is there. And so this is how it's reported in our system. So this is DSA. So you can see on the left, the usually over 1,000 is where we'd be concerned. And so you can see that this person had in the past DSA that subsequently went away. And so these are specific antibodies to specific MHC pieces that it's recognizing. And this is just a different graph showing how it's increased and decreased over time. So in this graph, for instance, this could represent a blood transfusion. This might represent a pregnancy, et cetera, et cetera. And so that's when they say antigen, it's recognizing it's antibodies that are recognizing a piece of the donor MHC molecule. And you can tell which particular one it is. So it's not just a flow match where you're taking cells from the donor. Um, And so this is basically discussing how we try to prevent the alloimmune response. And so um, the big numbers we look at are basically there were a bunch of drugs that were tried, just steroids, something called basiliximab, thymoglobulin, and then what's called um, alemtuzumab or Campath. This is basically showing that thymoglobulin is kind of our best one. And so the other one is that patients who were given alemtuzumab or thymoglobulin, they tended to have um, no change in survival, though they did have some effect on early rejection, even though it didn't affect the transplant of the kidney. So we tend to believe this that I think most centers believe that unless you have a very good matching organ, you should use um, thymoglobulin or alemtuzumab, and most centers are now leaning towards thymoglobulin because of the side effects of anti-CD52 therapy. So alemtuzumab is anti-CD52. And so just for your knowledge, most people should get thymoglobulin. Um, and so this is sort of the areas where we are trying to um, use medications for. So you've heard of calcineurin inhibitors, that's cyclosporin and tacromycin. Co-stimulatory blockade is belatacept. And then we talked about mTORs briefly, which inhibit mTOR. And azathioprine and mycophenolate are both involved in the cell cycle. They incorporate themselves into either they incorporate themselves into RNA or they inhibit the generation of new purines. And those are the kind of big five categories of drugs that we use most frequently, and will show up on your boards. And then this is just a brief discussion of why do so many patients that you see seem to be on tacrolimus, mycophenolate, and a steroid. And a lot of that is derived from this trial, which essentially looked at this trial actually looked at cyclosporin versus tacrolimus, or avoiding those and using an mTOR, and all the patients were on mycophenolate and steroids. And you can see that with standard dose cyclosporin, you had what was previously the baseline of rejection, and then they found out that with even low dose tacrolimus, it was very low. So this is why everybody uses tacrolimus universally. Um, and yeah, and this is the report of how people have been using these drugs more frequently. So tacrolimus, I think, was introduced in the early 2000s and pretty quickly was the majority of transplants. So, if you look at it, like 90% are tacrolimus and mycophenolate with or without steroids. Some centers use what's called a steroid sparing protocol where they withdraw steroids after the first month or two. These are a bunch of trials. You don't need to know about the details. Basically, there's no clear evidence that there's graft survival benefit. Most people use CNIs and try to avoid mTOR inhibitors. mTOR inhibitors have a lot of side effects, edema, hypertension, proteinuria are kind of the big ones. Very not uncommonly, you will see patients get FSGS from mTORs if they're on it for something else, like some other transplant. And then kind of the other interesting thing about mTORs is that they can potentiate bradykinin release from ACE inhibitors and cause angioedema. So you should not use them with ACE inhibitors unless you have a lot of caution with it. Um, This is just going over the lower risk. The reason we sometimes use, I think this will show up on your boards. So the reason to switch over somebody to an mTOR inhibitor is if they have lots of skin and soft tissue skin malignancies, and or if they have a lot of viral problems. So mTOR inhibitors originally were used as chemotherapeutic drugs and then had some brief life as antiviral drugs. I think mTOR inhibitors were actually studied in the COVID-19 pandemic and had good in vitro activity against it. So they have a lot of pleomorphic effects. And so if you ever get a question on like when to switch or who would you switch, it's somebody who has had a lot of trouble with um, skin cancers and or somebody who's had a lot of viral infections. Um, and then belatacept is sort of the co-stimulatory blockade. Big things to take away from this are that belatacept had um, like improved patient survival, so it's more benign over, I think, 4 or 5 years than mTOR inhibitors. But it was a pretty small effect, and then you had twice as much acute rejection. And so this is not a drug that most folks use right out the gate for management. Usually we keep them on CNIs for 6 months and then switch them over to belatacept unless we need to. The other big risk with belatacept is that you have to be EBV negative because if you're EBV positive, there's a high risk of not just PTLD, but PTLD in the brain, which is much worse prognosis than just regular old PTLD somewhere. So PTLD stands for post-transplant lymphoproliferative disorder. And then there's sort of two broad categories. One is EBV positive. Usually that's early. Oftentimes that's in the kidney itself. You'll find it on biopsy for AKI. And then there's late PTLD, which occurs months to years after the transplant and is usually EBV negative and usually is acts more like diffuse large B-cell lymphomas. Um, so big takeaway, if you're using belatacept, you have to check for that they're have natural immunity to EBV. Um, And so the big role, the most common reason, so most people with a kidney transplant die with a functioning graft. So that's the rule of thumb, meaning you die from heart disease, you die from stroke, you die from cancer. And so secondary or primary prevention is really important in this population, and we probably don't do as good a job as we should. If you do lose the kidney transplant many years out, the most common cause is antibody-mediated rejection. Um, and it's sort of becoming um, it's hard to treat. So this was a paper done by Dr. Cooper, who's our medical director, that looked at tacrolimus levels and the development of new antibodies against the graft. So, and he showed that if you have periods where your tacrolimus level dips below therapeutic because of whatever, you missed a dose or dosing variation, you're much more likely to develop antibodies against the transplant. And subsequently much more likely to develop antibody-mediated rejection. And oftentimes that's not like rip-roaring rejection that we have to do plasmapheresis and IVIG for, but it's more commonly what's called chronic antibody-mediated rejection, which is there's a lot of trials, but there's not a lot of good treatments for it. It's mostly antiproteinuric therapy and optimizing immunosuppression. So this is his trial and the development of new DSA. And so de novo DSA or new DSA is a very potent predictor of um, developing antibody-mediated rejection. And he looked at sort of the average tacrolimus levels over that period of time. And so the last thing I'd like to point out is I'm sure you all have heard of paired donation. So paired donation in the US has been growing quite a bit. And there's something called the Donor Care Network. So these are some articles I've reviewed, but a lot of people don't donate because of not because you mean like don't do altruistic or non-directed donations because they can't take time off work. They can't be sick at work long enough. The US does not have very extensive work policies that allow that. And so this was one of the centers that was founded to help organize these potential donors and provide them with some relief. The reason you cannot, for instance, just pay somebody to take time off work is because it was codified in the US law, federal law, to prevent essentially the sale of organs. And you can kind of imagine that um, that's been sort of a hot topic recently. So the NKR we were one of the founding centers, and among all living donors, so quite a few of them are now NKR supported or facilitated, and they essentially help provide lodging and support and also help provide like transport and find recipients for altruistic donors. And so this is particularly important for younger populations because, the average life of a living donor is 20, 25 years if you take good care of it and it's well matched. And so somebody who's in their 20s who's in kidney failure will need probably at least 2 to 3 kidney transplants. And they tend to have much better mortality than just like if you were to donate your kidney to somebody who um, you're related to or a friend of yours. And they tend to have longer graft life. And the morbidity benefits are to the recipient as well. And yeah, that was the big plug for the NKR. So sometimes you'll hear talk about the NKR or things like that. So that's what that is. So I've talked for almost 35 minutes straight. So I does anybody have any questions or comments, or does anybody want to ask anything about this? I tried to include like the dozen or so things that they most want to sort of test you on for your boards. Yes, Nana.
Question. So like tacrolimus is like preferred as like immunosuppressant, but then if you're having like donor related hypertensive like vascular changes, um, and then the talk is maybe switching to Elagicep, why would they say like like continue tacrolimus for 6 months? I'm just curious, like, was there a study that says like preferable to have that on at least for 6 months before you switch it?
So I think the original belatacept trials looked at belatacept as maintenance, not as the initial drug. So you guys kind of wonder why, like the 6 months we keep talking about. So, the idea is that if you get induction with thymoglobulin, you should be covered for at least 6 months. If you measure a CD3 count, it should drop. But those 6 months, you also have the most exposure to antigens, your immune system, because that organ is like not in great shape, right? It's been like taken out of somebody and put inside of you. And so the thought is that that's when you're at highest immunologic risk. Um, I think we all have seen like bad side effects from CNIs before, but it seems weird that like some people can be on CNIs for 30 years and do fine, and some people get like progressive CKD and we blame CNIs. And I'm not 100% sure if we necessarily have a good handle on CNI toxicity and how it affects either native or transplanted kidneys. But yeah, that's the rationale. That's why the 6 months is supposed to be the highest immunologic risk. And you can imagine that's why we see them so much in the first 6 months, 6 months to a year.
Thank you.
Yeah. All right. If there's no other questions, I'm going to give you guys your time back. Have a good day.
No, I did not. I decided not to sign any, and I was just gonna talk you guys through it. Pretty self-explanatory, article, but this was the Mentor trial, looking at rituximab versus cyclosporin. Um, primary members nephropathy, it came out in 2019, and then it changed kind of the scope for members nephropathy. Um, so membranous nephropathy is one of the leading causes of nephrotic syndrome. And we kind of know the third rule, spontaneous remission in the third patients. The third patient go on to have nephrotic syndrome. And then of those, then the third of those go on to develop ESRD. And then now we know about 70 to 80% of these patients are positive for PLA2R. And the other 1 to 3% have this THSD7A antibody, and then the rest is unclear what their pathology is. And then they found that the anti-PLA2R antibody, there is a very strong correlation between antibody level and disease activity. And so the study then looks at um, kind of the treatments that historically we're looking at CNIs, mainly cyclophosphamide and steroids. Cyclosporin has also been used, but there's a lot of side effects with CNI that we know of, like hypoglycemia, hypertension, it's nephrotoxic, you have all these other stuff. It's very unselective. And because they know that B cell dysfunction is a big role in membranous nephropathy, we looked at maybe let's do a target therapy with rituximab. And so these were kind of the two studies that was around this time that this study came out. But Mentor trial was the one that did the longest follow-up for about 2 years, 4 months. And so Gem Ritux in 2017 just kind of looked at, does Ritux work? It was a multi-center randomized trial, but they only looked at endpoint of remission at 6 weeks. And we kind of know now that Ritux doesn't really work that quickly. And so in that study, they kind of found it comparable to supportive care. So there really was a positive study. And then Starman in 2020 looked at tacrolimus followed by rituximab versus the Anselli regimen, which was what was pretty much what most people were doing with the corticosteroids and cyclophosphamide. And they found that cyclophosphamide was superior with higher rates of remission compared to doing tacrolimus plus rituximab. And so in this study, they looked at the efficacy and safety of rituximab versus cyclosporin in patients with membranous nephropathy. I'm just not using my computer. So in this study, they looked at 130 patients, and it's a multi-center, 22 sites in North America. It was randomized. It's hard to do closed label when one is infusion and one is giving them PO meds, so you can't really blind that. So it's open label. It's a non-inferiority trial. Included 18 to 80-year-old adults with biopsy proven membranous nephropathy, and they had to have a nephrotic range proteinuria at least 5 grams in 24 hours. And then this is the creatinine clearance of greater than 40. And then they did have to have been on RAS blockade for at least 3 months. And then I thought this was nice that they make sure that they're on the best practice supportive care. And then the study follows up the patient for 24 months. And then this was kind of the main thing, that rituximab versus cyclosporin. But the best practice from the study basically said, like, they were maintaining the blood pressure less than 130/80, they're restricting their sodium, they're keeping an eye on how much protein, all the things that can affect proteinuria, which is one of their outcomes they looked at. And then for people that weren't on ACE or ARBs, then they did a 3 months run in to make sure that they met this criteria, and then their proteinuria was still greater than 5 grams. The interventions were rituximab. They did 1 gram, 2 infusions, 14 days apart. And then at 6 months in, they'll look at if there's complete remission of proteinuria. They don't give any additional treatment. If proteinuria fell by at least 25%, then they'll give a second dose of her second course, so another 1 gram, 2 infusions. And then if proteinuria was reduction was less than 25%, then they exited the study and they were included. And then cyclosporin, they did 3.5 milligram per kilogram per day over 2 doses given at 12-hour intervals. Then they targeted this trough. And then they also observed if there was remission or reduction in proteinuria, and if they weren't reduced by less, if the reduction was less than 25%, then they exited the study. And so that was kind of the dosing for the interventions. And then so like this was from the supplementals of how they did it. So they did 6 months, and then if you had some response or complete response, you were continued in the study. And if you had non-response or the reduction less than 25%, you were considered a failure of the treatment, and then you exit the study. And I'll talk about the people that exited the study. And in terms of, they assessed 182 patients, excluded them from not meeting criteria, randomized 130, and then so 65 received rituximab, 65 cyclosporin, and then this was kind of the stuff that was just lost to follow-up where they stopped the intervention. And then they analyzed that data. And then the comparison between the two groups were relatively similar. I think there wasn't much difference. If you guys can see any, shout them out. But I think the main thing was that they didn't talk about what type of ethnicity they were. That was kind of the thing, was they didn't talk about like what the diversity was in this. But relatively, sex was pretty well matched and there was like, the other thing was like the PLA2R, they didn't really stratify the degree of PLA2R, they just had to be positive for it. So the primary outcomes they were interested in was complete or partial remission of proteinuria at 24 months. Complete remission was less than 0.3 grams per day, and then partial was less than 3.5 grams. And then they looked at all these other things like how do the PLA2R levels come down, creatinine clearance, adverse events, etc. So at 12 months, you saw that 60% of the Vertex group achieved complete or partial remission, and then 52% in cyclosporin had complete or partial remission. So it's relatively comparable. I think what was really interesting was when you look at 24 months, then you're seeing 60% for the Vertex group, but then this big drop to only 20% the cyclosporin group. So it's a very big dramatic difference. And then we kind of looked at the numbers more closely. 23% had complete remission in the rituximab group at 24 months. And then of that, the PLA2R was negative at this time. And then when you looked at the cyclosporin group, 0 patient had complete remission at end of 2 years. So that was a big difference. And then, so basically when you look at the figure 1, it showed that induction phase was kind of the numbers I was talking about initially, and then the maintenance phase, it was like that big dramatic difference. Questions, concerns? I mean, this was another one looking at, it was just more numbers. Didn't really find anything particularly interesting in this one. And this one, was the one to address like treatment failure, so this was,
That's a good difference.
yeah, so this was the one addressing the people that got like. Basically ended being part of the study in a way, but you know, it's still a high percentage, 40% of the rituximab patient had treatment failure. And then, but it's 80% the cyclosporin group, so it's pretty dramatic. So the key insight from this and the big conclusion was rituximab was found to be a non-inferior to cyclosporin, inducing proteinuria remission at 12 months. And then it was found to be superior, maintaining long-term proteinuria remission up to 24 months. And they didn't really study beyond that, so we don't really know what the numbers would be at that point. And then we kind of saw the cyclosporin group relapse pretty heavily. And then they looked at kind of the other endpoints. Let's talk about adverse events. So I think rituximab, we kind of know from when we tell patients about adverse events like infusion-related reactions, feeling like influenza symptoms. So it's kind of the main adverse events for rituximab. And then we know like the GI symptoms, nausea, vomiting, hyperkalemia, was like, but I think this one, they have relatively similar respiratory tract infection rates when you look at across the board. And then this is a more dramatic increase in creatinine level for the cyclosporin group. But overall, adverse events are pretty similar. And then talk about the infusion reactions, and then everything was more GI symptoms and increased creatinine. This one was a really nice graph from the supplementals that they show that for the PLA2R positive patients, you could see a very dramatic rituximab drop the levels versus like cyclosporin. So that was a really fun graph to look at. But then when you look at initially, the PLO2R and the proteinuria levels, you'll see that, the drop in the PLO2R is like faster than the proteinuria. So a lot of times we might not see right away the proteinuria decrease as much as doing like a CNI, but then overall, like long term, you'll see that proteinuria improve a lot. So I think that was one of the big theories, that the immunologic remission will be seen before the clinical response. And then this is a nice little summary of everything. And then we already talked about the numbers, and overall adverse events was less in the rituximab group as well. And kind of a big takeaway questions. So strength is a randomized controlled trial, is at multi-centers. The longest follow-up that's been seen for rituximab and membranous nephropathy. It is open label. It's a very small sample size. It was like 130, and of that, we saw a couple of people didn't fully finish the study because they weren't responsive to treatment. So it's a very limited power for what we can say about the secondary outcomes. And then they also didn't use like cyclophosphamide, which is one of the big treatments that's recommended. GeneTech donated the rituximab for the study. And then there was poor characterization of what the patient diversities were. So it's hard to say, does it correlate to our patient population? But overall, this was a very impactful study. Now rituximab is considered first line for moderate to high risk membranous nephropathy. It's actually preferred over CNI for durability. And that's kind of the takeaway from the study. And it supports what we thought about targeted B cell treatment. And this is from Digo about, so you'll see like low risk, we wait and see, moderate risk, and rituximab with CNI, and then like down here as well. So that was a very landmark changing study.
Could we go back to the background slide or the background study?
Yeah.
It's slide 3, I guess.
Yeah.
Okay. But I just wanted to mention RI Cyclo,
Cycle was a big one. Okay.
the 2021 study that compared Rituxan to cyclophosphamide. I just wanted to
What does it say?
non-inferiority. It wasn't really powered that high. There was it had like 70-ish patients, but it was non-inferior in 24 months. So that's why I like Rituxan's.
For rituximab.
Yeah, above cyclophosphamide and like Starman. I think they gave 1 dose, right? Of Rituxan.
Yeah.
I don't think I gave
They were
2.
more like relying on the tacrolimus.
Yeah.
And I just randomly threw it in there.
They just threw like a 1. I don't know that I can't remember if it was 375 or 1 gram or whatever, but I think they just threw 1 dose. So it's like different.
I think it's like maybe 500. I don't remember.
Oh.
I have to look at it again.
It doesn't matter. I was just
Yeah,
saying
no,
like
that's good to know.
different than this study and RI Cyclo.
Is that one, is it like Michelli, like with the oral cyclophosphamide?
Yeah.
So like IV.
Oral, they did the 6-month alternating.
alternating.
Yeah, the 6-month alternating corticosteroids.
Cause I feel like, well, cause like now in the like guidelines, it's like. Really only cyclophosphamide is like first for like the super high risk.
Yeah.
But then I feel like at that point, you're probably using. IV and then doing like I don't know, like when we did it at Denver Health, we did some sort of like made up similar to like kind of similar to Cyclops dosing.
Oh, I kind of had you like James
It was
made up
Jamie's made up.
Anko one because he does Anko.
Jamie made it up, so yes.
Yeah.
I think it might be the same.
I think there's like
Is that-
English people who do both. I don't know.
I think it came from somewhere, like he didn't just make it up off the top of his head.
There's this random English nephrologist that he references all
Maybe
the time
it's
for
that.
this, and this guy like does Cytoxan and Ritux on all his
Oh.
patients. There's a few
But
like
just
small.
the thought that the high risk one don't get rituximab. So I feel like that was like, because they were saying like this part, would they agree with rituximab, but it maybe just might be the studies they looked at.
Yeah, it might just be inclusion criteria. I don't
Yeah,
know.
include it and then
Yeah.
they did.
Cause the very high risk is like their kidney function is bad, basically,
Yeah,
is what puts them in the very high risk, is they're having like rapidly worsening
isn't it like,
kidney function, so then I think it kind of puts you in like. I don't know, like I feel like it's like the vibe of it is more of a RPGN
yeah,
than a membranous, and I don't know how they came up with it though.
And then
I
just
think-
bomb them.
I think
Yeah.
Dr. Podol is part of that new trial, I think, recruiting for it.
For OB,
No, not OB, it's Rituxan, you do Rituxan like Mentor 1 gram at day 0, 15. But you do a run-in of Benlysta for 4 weeks.
Huh.
To tamper the BAFF activation, and then you do the CD20 depleting.
so nice.
And for membranous,
Yeah.
I feel like they're trying to put Benless on everything now.
I think it's because they found when you do all these B cell depleting therapies, the
Yeah.
BAFF levels just shoot through the roof to compensate.
Hmm.
So I think that's why.
Interesting.
But I do know that that burn patient was in Dr. Portal's.
That's why I have-
study. for
Oh.
membranous.
Oh, they got mad at me about that burn patient.
We're friends now,
Alright,
I think, except it's on Depot out of this, I don't know.
I don't know.
I don't remember what I did though.
They said they were
I
gonna,
wanted to sign off every day, I was like, we're just doing whatever they wanna do, can we just?
Oh,
sign
the
off?"
burn patient, they wanted
The
you
name
out.
by chance?
Okay.
they said they were gonna.
Oh, yeah, we signed up,
So,
Did you get reported?
they eventually apologized to Young the next day, but they said they were gonna report us for not doing CRT.
And he never needed it,
No.
did great.
So,
But if the consult, do you feel like we need renal
Oh,
replacement
yeah,
therapy?
bullshit console for you guys.
well, I got it and, but,
It took us, it was so funny too, because it was like. Well, it's like I'm seeing him like a couple of days after like we didn't start CRT, and they're like, hey, he's getting volume overloaded. And I was like, fix it, more around fluids now. Okay, next day. They're like, okay, we'll slow the fluids down.